Good afternoon. I'm Cynthia Corbett, and I'm here with my colleague Steve Setter. And as you can see, our project is about home care nurses and helping patients and home care nurses resolve medication discrepancies after they've been hospitalized. And so some of you might be saying, well, what exactly is a medication discrepancy? And the way that we define it is it's not necessarily an error, but it's a mismatch or an incongruence in what the patient says they're actually taking and putting in their body and what the physician or the home care nurse or anyone else thinks that they're putting in their body. It could also be something like they have an allergy and that's not listed on their medication record. So as I've been listening to people talk, it's been interesting because I see a lot of people are looking at medications as one of the quality outcomes. So I think it's definitely, most of us in this room anyway, recognize the importance and the significance of medications and what they do for health and outcomes of health care. But I think there's a great insignificance in the part of the general public, that it's such a part of our culture that we just take it for granted that medications are safe, especially if they're over the counter. And so we have a great a deal of discrepancies that we're finding. And am I supposed to change my own slides here? As you'll see here on the bottom point there, we've found in our study that we have about almost 90 patients enrolled so far, and there's only been 2 that have not had a discrepancy identified after their discharge from the hospital. And most of them have several, 5 or 6 is about the average. What we've, where we're at now, what we've learned is that communicating between differing proprietary EMRs is difficult and costly. One of our goals, some of you may remember, is that we were hoping to have a system that automatically identified medication discrepancies for the nurse. And fairly early on, we decided not to do that amount of automation, partly because, well, there was about 3 good reasons. One, we found out that those systems already exist. People have already put resources into building them, and so they already exist. When we looked at them, we found out that it takes multiple steps and quite a bit of time, actually, to identify the correct medications and have that done. So we didn't actually think it would contribute to efficient nursing care. And when we talked with the nurses about this, they agreed with us that they said, no, we'd much rather just have an accurate list from the hospital discharge that was in a nice readable format that was electronically sent to us that we could then compare with what the patient says they're taking. And the second thing that we learned, or third or fourth, that we learned about that is that oftentimes the nurses do not take their computers into the home because there's MRSA or some other issue related to infection control or safety that they don't want to take their computers into the home. So anyway, so we've modified that somewhat. And in terms of a microsystem, that was even what we have done in terms of connecting those 2 EMRs has been quite challenging and time-consuming, and so that's on a very small microsystem. So we're just seeing a very little glimpse of what the challenges are ahead for the United States healthcare system if we think that we're going to do that with our whole healthcare system. It should be interesting. We are about, in terms of where we're about 1/3 complete with our recruitment, and we have, fortunately, we have started this project with clinical agencies that we've already had excellent relationships with, and that has proved very fruitful and helpful. And so that whole process has gone fairly smoothly, and I can't hardly imagine doing a 2-year project in one that you really had to already establish those, that you had to go in and establish those relationships. So I can feel for some of my colleagues who have described doing that. We did unexpectedly find that the hospital discharge planning process is fraught with significant challenges, and mainly that our home care coordinators that are getting the referrals for their employees of the home care agency, and they work with the discharge planners to get referrals for home care patients, and then we want to enroll those patients in our study before they leave the hospital. We have found that they get about a third of the referrals they get never actually go to home care. So we've enrolled over 120 patients, but only 90 of them are still, active study patients because they didn't ultimately get discharged from the hospital and go to home care. The majority will go to skilled nursing facilities, a few to hospice. Some end up not being eligible for home care, a variety of things. But we hadn't anticipated that level of loss of recruitment at that stage, so that's been a little bit of a challenge. And then, as I said, almost all of the patients have discrepancies, much higher when we're actually doing it at this prospective level than what we've seen in the literature. And why does anyone care? Well, as I've mentioned, that certainly medication is, appropriate medication taking is a quality and safety issue, and I think that's well recognized. Also a healthcare cost issue. If any of you have had yourselves or family members in the hospital, I'm sure almost everybody would have a story about what happened when they were discharged and medications that they thought they were supposed to be taking or weren't taking. And just on a more intimate level, I'll just tell you briefly about one lady we had who I'll call Mrs. Smith, and both of our research assistants were on vacation, so I actually had the opportunity to go and try to recruit Mrs. Smith into our study. And she was a delightful 88-year-old woman, and I came into her hospital room, and I introduced myself, and I said to her, we're doing a study on problems that sometimes people have problems when they're discharged from the hospital with their medications, and because they've started new medications and this and that. She was sitting up in the chair, and I was sitting on the bed, and she listened to me for a while, and she looked at me, and she said, I've just been thinking about that. And I said, you have? And she said, yeah. She said, I came in here, and my heart was really beating fast, and then they found this blood clot in my leg, and she said, and I just know I'm going home with all these new medications, and my daughter-in-law is not going to pick me up until 4 o'clock, and I'm just hoping that I can get them all filled, that late in the day. And so anyway, she subsequently was enrolled in our study, and unfortunately, when the nurse went to see her, she did not have her Coumadin, which is the blood thinner that she needed for her DVT, deep vein thrombosis. And so she said to the nurse, I just don't know what I would have done if you wouldn't have come to see me. And the nurse said, well, I don't either, but I think there's a good chance that you might have been rehospitalized in a few days. So hopefully we are making a difference in nurses and identifying these problems so that we can find better solutions to work with them in the future. So our hopes for the future is that we can find a solution to medication discrepancies, which constitute a universal challenge. We think that solution might be to try to prevent more of them. It certainly doesn't happen just from the hospital to home. As I think we'll hear tomorrow, people come to the hospital with not an accurate list, and it's just a real revolving circle. We do think while technology has a place in medication and medication management, we think that there's also a very real need for patient-provider communication and a good rapport. And so I don't think we can ever forget that part, that we do need that relationship and the talking between patients and providers. And so we do hope that someday our work might contribute to this solution. And then our team, as you can see, we have a fairly large team. I did include Steve Setter and I, and then you can see we have a fair amount of pharmacists and other nurses. Ken Duratha is our health informatics scholar, and Doug Weeks is a statistician. David Sklar, in addition to being a pharmacist, his background is in health policy and economics for his PhD. And then our research assistants and associates, and also Aaron Clark and Ann Hallstrom are our two nurse interventionists at the home care agency. And then our consultants are Dr. Eric Coleman and Dr. Janice Faust.